My name is Alana Dillon. I'm the Education and Support Service Coordinator with Parkinson's Society BC. Welcome everyone to our first talk for our September Symposium on frequently asked questions about Parkinson's disease with Dr. Squires. Before I introduce Dr. Squires, I want to go through a few housekeeping items with you. First, I wanted to let you know that we are recording this webinar, so it will be available on our website. And secondly, you'll see a chat box, so please feel free to use this chat box during the webinar to make any comments or questions. And finally, to optimize your experience with this webinar, please ensure that you adjust your speaker volume both on your computer as well as on your actual speakers so that you can hear the webinar. And sorry, I should have asked if everyone can hear me. If you can hear me all right, please type yes in the chat box. Okay, perfect. It looks like people can hear. Also, I wanted to remind everyone that registration for the 30th Annual Parkinson's Super Walk is now open. It's very close, the 12th and the 13th of September. And as part of this year's event, we will be offering monthly exercise and fundraising challenges. And as I said, the walk weekend is taking place on September 12th and 13th. And the funds raised from Superwalk, they help us continue to put on education events like the webinar you're attending today. So we really encourage you to visit www.parkinson.bc.ca/superwalk. And I've also put it in the chat box for you. So feel free to click on that link after the webinar to learn more about it and to register. I would now like to welcome Dr. Squires, who is a movement disorder specialist at the Pacific Parkinson's Research Center. And he's here today with us to address frequently asked questions to provide clarity and insight for the Parkinson's community. Dr. Squires, welcome, and thank you for being here with us today. I'll pass it over to you now.
Great, thanks, Alana. Thanks for the invitation to come and speak. So I was asked what I wanted to give a talk about, and I thought that I would sort of give a bit of an overview addressing the questions that I find myself answering frequently during my day. This is not in any way sort of a scientifically based thing where we went out and asked people with Parkinson's what their most frequently asked questions are. This is really my gestalt. So it looks like people may have lost the audio. It sounds like there's a mix of people being able to hear and not. Can anyone other than Christine hear me just before we start? Audio back? Okay, good. And just let us know if there are any problems as we move forward here as well. And I see some familiar names in the attendance list. I don't know that you'll learn much new today, so I apologize if that's the case. Hopefully I'm at least internally consistent with my answers. So as I said, we're going to go just over this is not an in-depth overview of Parkinson's disease. This is going through just some key points that I find people are often curious about. And I have no disclosures related to this talk. So first we'll start with what causes Parkinson's disease, the most burning question. So Parkinson's is the second most common neurodegenerative disease after Alzheimer's. So neurodegenerative disorders are, of course, a family of disorders where certain populations of brain cells slowly die away. For almost all of these conditions, we don't really know the cause, though with Parkinson's disease, we know somewhere in the ballpark of 5 or 10% of people have some kind of genetic factor involved in their Parkinson's disease, either as a direct cause of the Parkinson's disease or in increasing their risk of developing Parkinson's disease. We do know that if you have a first-degree relative, so that's a parent, a sibling, or I suppose a child who has Parkinson's disease, then it roughly doubles your risk of getting Parkinson's disease, which sounds like a lot, but only about 0.3% of the population is affected by Parkinson's disease. So if you double that, it's still a very small risk of getting PD. So for most people, we have no idea why they have Parkinson's disease. In most cases, there's this protein called alpha-synuclein, which is a normal protein. But in people with Parkinson's, there are abnormal fragments of this protein. So it gets broken down in an abnormal way compared to usual. And something about these fragments seem toxic to the neuron, the brain cell. So the brain cell will mop up these fragments and put them in a package that we call a Lewy body. And in the picture at the bottom, at the top of that clump in the middle, there's a purple hazy thing. That's a Lewy body. So when you look at a neuron under a microscope from someone with Parkinson's disease, that's what you see. And that's the defining pathological feature of Parkinson's disease. Not everybody with Parkinson's has Lewy bodies, though the vast majority do, and that's not entirely clear. Certain of the genetic forms don't seem to develop Lewy bodies, and we're not sure whether it's the Lewy body that's toxic or if it's the little fragments of the alpha-synuclein that are toxic, and the cell is trying to mop them up and wall them away as a protective measure. So we don't really know. We do know that there are risk factors for Parkinson's disease. So men are more likely to get Parkinson's disease. And the older you get, the more likely you are to get PD. Those are the two best established risk factors. And it does seem for some reason that people who smoke cigarettes are less likely to get Parkinson's disease. Not an advertisement for smoking, but that is, presents interesting research questions as to what's going on there with cigarette smoking. And I'm just going to take a second just to scan the chat bar here, just make sure that, okay, looks like there's some on and off audio issues, but I'll carry on. And just a note about the questions, I do have a pause sort of partway through this presentation, which will be obvious when it comes. And what I'll do is look at the questions at that time. If there's anything that's not going to be addressed later on, I'll address them after we take a little 5-minute break. And then anything else, we'll have lots of time for questions at the end. Another big question, what is the difference between Parkinsonism and Parkinson's disease? So when we talk about Parkinsonism, what we're talking about are symptoms. So it's an umbrella term that really describes the symptoms of Parkinson's. So it's the resting tremor, the muscle rigidity, and the bradykinesia, or the slow, clumsy movements. And also the small handwriting, the quiet speech, all of those things are manifestations of bradykinesia, which means small or slow movement, essentially, in Greek. So Parkinsonism, when we talk about Parkinsonism, we're describing those symptoms. So it's not a diagnosis. And when we diagnose you with Parkinson's disease, the first step is to say, okay, well, do you have Parkinsonism? Because without Parkinsonism, you don't have Parkinson's disease by definition. And then once we establish that you have Parkinsonism, we have to do our best to try to figure out why. And Parkinson's disease is only one cause of Parkinsonism. It's the most common cause, but there are other things. And that's where the uncertainty around the diagnosis can come in. And if it's not Parkinson's disease, then what is it? So it turns out that there's another few much less common neurodegenerative diseases that mimic Parkinson's disease. And also certain medications can cause similar symptoms. And those are usually medications that are used to treat psychiatric disorders, particularly schizophrenia, bipolar disorder, and some anti-seizure medications as well can cause similar symptoms. And it can be sometimes quite tricky to tell them apart. So brings us to how do we diagnose Parkinson's disease? So I have, quite a number of, not that infrequently, someone will come to me as a first visit and they say, oh, this quack doctor, all they did was make me sort of wave my hands around and then they told me I had Parkinson's disease. Well, disappointingly in 2020, that is still how we diagnose Parkinson's disease by and large. So it is a clinical diagnosis, and that means that there's no test that we have. So the diagnosis is based on talking to you and figuring out what symptoms you're having, and then examining you and looking for those cardinal features of Parkinsonism. So the tremor, the slow movement, that sort of thing. And not everybody has tremor, of course, so you don't need tremor to have Parkinson's disease. The only way to definitively prove that you have Parkinson's is to do an autopsy, which in my experience has not been a popular option for people. And then there is this test that many people have read about called a DAT scan, which is a nuclear medicine test that labels some of the dopamine neurons in the brain. That just got Health Canada approval actually last year, but it's not any more accurate than being assessed by a neurologist, essentially. So there's a lot of false negatives, particularly with DAT scans. So we know from studies where they compare people who've had autopsies and look back at their charts and say, okay, well, what did we think that they had? We know that we only get the diagnosis right about 2/3 of the time in the early stages of Parkinson's disease. We get better as things progress, and the longer you've had symptoms for, the more confident we are in the diagnosis. But even still, at the time of death, we've misdiagnosed about 10% of people with Parkinson's disease. So this is disappointing, obviously, and there is a lot of research going on trying to find that test or combination of tests that will give us a more accurate diagnosis. And that's really important, particularly if and when we find a cure for Parkinson's disease, because obviously we want to give it to you as soon as possible, and we want to not give it to you if you don't actually have Parkinson's disease, because of risks associated with any treatment potentially. So why is it so hard to diagnose Parkinson's disease? So as I mentioned, there's this other family of neurodegenerative disorders that can cause Parkinsonism. And in the first few years, up to 4 or 5 years, or sometimes longer, they can be completely identical to Parkinson's disease. So these are uncommon conditions: multiple system atrophy, progressive supranuclear palsy, dementia with Lewy bodies. As a bit of an aside, thinking around dementia with Lewy bodies is shifting a little bit, and many people now believe that it's a subtype of Parkinson's disease, sort of on the same spectrum, but that's kind of neither here nor there. It's a bit of an academic, nerdy aside. So how we figure out whether you have one of these other things is that we follow you over time, and we have a broad idea of how Parkinson's disease should progress and what kind of symptoms to expect, although that's highly variable from one person to the next. So what we do is we're on the lookout for symptoms that come up that we don't expect to see in Parkinson's disease, or that we might not expect to see until someone has quite advanced Parkinson's disease. So for example, someone ending up in a wheelchair in the first 5 years of symptoms would be very unusual for Parkinson's disease. And it makes up what we call red flag feature that suggests that maybe you have progressive supranuclear palsy instead, for example. But it's not always very easy to tell them apart. We do end up treating everybody kind of with the same drugs, which is kind of, again, very disappointing in 2020. And so in some ways, it's a bit of an academic distinction, but it does carry important information about prognosis, because these other conditions tend to progress more quickly than Parkinson's disease, and they often don't respond very well to treatment for the symptoms. And so it's obviously, as soon as we figure it out, we will let you know. I mean, hopefully people will let you know. I certainly would. So every time I see a patient, I'm always in the back of my head saying, is there anything atypical here? Do I need to be worried? And I have a few patients where I'm like, I have coded notes to myself in my consult letters saying I need to be particularly attentive to certain people because there's little things that make me a bit uneasy, but they're not quite to that degree yet. Is there a cure for Parkinson's disease? Unfortunately, not yet. There are sort of hopefully promising drugs in the pipeline. So some companies have taken some of the more common genetic causes of Parkinson's disease. So for those people, we know why they have Parkinson's, presumably, and we know what problem the genetic mutation is causing along the brain pathways, and they've developed drugs to try to reverse that problem. So some of these drugs are in trials. Hopefully they'll pan out. And what we hope is that in addition to treating those genetic causes, there may be other people out there who don't have a genetic mutation, but have the same problem for a different reason. And it might help at least cure a subset of people. And the more people we can peel away, the more resources can then be devoted to the other people. For now, the best that we have is that exercise does seem to slow the progression of Parkinson's disease. So what type of exercise should you do? It's a great question. We don't really know. My personal bias is that if there is a best exercise for Parkinson's disease and you don't like it, then you're not going to do it. So you're better off just finding something that you like to do and sticking with that. Right now, the current recommendation is to do 30 minutes of moderate intensity exercise every day. Moderate intensity means that you get your heart rate up a little bit and you're breaking a bit of a sweat and you're very slightly short of breath. So you could have a conversation with somebody you were exercising with, but you'd have to pause and catch your breath after every, I don't know, 4 or 5 words. You're not reciting poetry while you're walking, type of thing. So the slow amble around the block while your dog stops and sniffs things isn't going to cover it, but you need to get your heart rate up a little bit. So some kind of mix of cardio, strengthening exercises, stretching, and balance seems to be optimal. There are lots of Parkinson-specific exercise classes out there. So there's power moves, boxing, dance, etc. And then a few types have been more systematically studied. So Tai Chi, Qigong, yoga have been shown to improve balance and reduce the risk of falls for people with Parkinson's. Okay. So moving along, what diet should I follow? So right now, there's no particular diet that's recommended for people with Parkinson's disease. Some people, 15% or so, find that if they have their medication too close to protein, that their medication doesn't work as well. But for most people, you don't need to worry too much about it. We do have research around this diet called the MIND diet, which is a sort of a modified Mediterranean type diet that seems to suggest that the people who follow the diet most closely are less likely to develop neurodegenerative diseases, including Alzheimer's and Parkinson's disease in the first place, and seems to slow down some measures of brain aging. So the MIND diet is basically lots of fresh vegetables, berries, nuts, olive oil, oily fish once a week, and moderate intake of wine. Nothing in excess, of course. Basically more plant-based food, less animal-based food, and that seems to help overall. On the sort of nutrition bent, what supplements should I take? Unfortunately, to date, no supplements have been shown to affect disease progression in Parkinson's disease. So lots of supplements have shown some benefit either in animal models or in brain cells in a petri dish, where if you add in various things, antioxidants and whatnot, it slows down the death of those cells. But any of them that so far have been studied in humans, unfortunately, haven't worked. And part of that is because animals that we study them in don't get Parkinson's disease. We usually have poisoned them with something to kill off that population of brain cells. And so if you yourself have not been poisoned with the same substance, those studies may not be very applicable to you. And by and large, most people have not been poisoned by one of these substances. And similarly, even in the animal models where they've inserted a genetic mutation, a human genetic mutation that causes Parkinson's, those animals' brains don't behave exactly like human brains do with the same mutation, so they're not perfect. So we haven't quite gotten there. The other factor is it may be that some of these supplements would work, but you may need a cocktail of things. And so on their own, they may not work, but if you take 5 things together, maybe it would have some benefit. To date, as far as I know, nobody has really studied combinations of supplements, or for that matter, combinations of pharmaceutical drugs that might offer a cure for Parkinson's. Meanwhile, for symptoms, magnesium sometimes can help with constipation and leg cramps, and sometimes restless legs. So the trick with magnesium is there are different types. Some types are absorbed better than others. The less well it's absorbed, the more of a laxative it becomes. So your pharmacist can help you sort out which of those things are better. You just have to be a little careful if you overdo with a laxative. Vitamin D may be beneficial. There are some early studies that may show a link between vitamin D deficiency and getting Parkinson's disease, but not anything definitive as of yet. Having said that, particularly at this latitude that we live at, most of us are probably a little bit vitamin D deficient, and so it doesn't hurt us to supplement. So 1,000 or 2,000 units a day seems adequate. Several supplements have been studied in humans and with good quality studies and have shown to be ineffective for disease progression. Those are listed there. So vitamin E, coenzyme Q10, creatine. There's been probably one or a few others, but so far nothing we can definitively recommend. Now, very topical. Am I at higher risk of COVID-19 or having severe disease from COVID-19 because I have PD? So, unfortunately, there have only been a few reports of COVID-19 with Parkinson's. I can tell you that the Movement Disorder Society, which is the international body that sort of oversees most of the research effects or efforts into Parkinson's, has a registry, and there's a lot of ongoing interest in sorting this out, but we don't know yet. In general, we don't consider people with PD to be immunocompromised. It does not affect your immune system. However, people may have other issues. For example, if you have swallowing issues, you may be more at risk of getting pneumonia in the first place. What I can tell you is that from the centers mostly in Europe that have reported their hospital experience with Parkinson's disease, they do seem to see a few more severe cases in people with Parkinson's. However, pardon me, those people presenting with more severe disease, you are more likely to have high blood pressure, diabetes, which are risk factors that we know of in the general population for severe COVID-19, or they have dementia or very advanced Parkinson's disease. And so they're quite frail and again, would be at higher risk of COVID based on their frailty, whether they had Parkinson's or not. And so it doesn't seem to significantly increase your risk if you're younger, healthier, etc. And then with that, we're going to take a couple-minute break. I see that there are a few technical issues here. This is my dog with his COVID protection mask very shortly before he ripped it off. So we're going to take 5 minutes, get a new cup of tea. We'll see if there's anything can be done with some of these nagging technical issues. I will have a look through what questions you've posted, and we will reconvene here at about 1:28.
Sounds good. Thank you, Dr. Squires.
Okay, everybody. So why don't we get started again? Thank you for your questions. I'll just have a look, answer some of these, as I'm not going to directly address them. So one question about whether DAT scan is covered by MSP. It's not as of yet. For most people, honestly, it doesn't add much. The only time for me that it's particularly helpful is in the instance where I'm not sure if someone has Parkinson's disease and there are some confounders present. So those people, for example, who have had schizophrenia for their entire lives and they've been on medications that we know can cause Parkinson-like symptoms, but they're 65 and maybe they're also developing Parkinson's disease. In which case the DAT scan might be helpful, because the DAT scan should be normal if it's symptoms from their medications, pardon me, but might be abnormal if it's Parkinson's disease, but might not be. And the problem with the DAT scan is that if you have the symptoms of Parkinson's in a normal DAT scan, you probably still have Parkinson's. And so it doesn't really help too much in that regard. So I don't think it will ever become a routine part of the workup, or at least I hope it doesn't become the routine part of the workup, because I'd rather that MSP spend their money on things like increasing access to deep brain stimulation and other therapies. Now, let me just scroll down here. Should genetic testing be part of the workup for everyone with Parkinson's? Good question. So for the majority of people, if we were to do genetic testing, it would be normal. If you're somebody with either a strong family history, so multiple people with Parkinson's across multiple generations, or you're very young when the Parkinson's starts, so under the age of 40, there's a higher likelihood of finding a gene. Having said that, whether you have a genetic form or not, it doesn't change your treatment, though of course it has implications for your family. And some people might make decisions about having children or not based on the result. So if it were going to change something, then it could be something that you could pursue. We haven't had much luck getting coverage for genetic testing because currently it doesn't affect treatment. However, for people who are very interested, there is a lab that will offer a panel of Parkinson's genes for about $300 US. They send you a saliva kit to your home, and then they generate a report. Your doctor, I think, has to refer you for it, but it's not that expensive. Having said that, there are more than 30 genes now associated with Parkinson's. That panel only covers something like 16 of them, I think. And so you may get, again, a negative report, but there may yet be a genetic underpinning. What I think will happen is that if there are treatments for genetic subtypes, then the genetic testing, at least for those subtypes, will be covered, because it would then make you a candidate for the treatment. For right now, it's kind of more of out of interest or family planning decisions. How often should I visit my neurologist? There's no one right answer for that. If everything's going completely well and you're feeling fine, then once a year is probably perfectly adequate. A lot of people will do every 6 months. Some people with more advanced Parkinson's will see a neurologist every 3 months. Often we're a bit limited by person power as to how often we can see people, so there is a little bit of a variability, but it really just depends on how you're doing, essentially. Is a multivitamin okay? Definitely multivitamin okay. Like I said, there's no supplements that are routinely recommended. There are no supplements that I'm aware of that cause harm to people with Parkinson's. So if you're taking things for other reasons, or you are a believer in supplements, then by all means, it's not going to hurt you. We just don't know of anything right now that will definitely help. Are Parkinson's and amyloidosis related? Not really. They are, I think you're talking about transthyretin-related amyloidosis, because amyloidosis is a bit of a nebulous thing, and a few different diseases fall under that umbrella, but there is a treatment for transthyretin-associated amyloidosis to reduce production of the abnormal amyloid. That is a specific treatment for that abnormal protein, and not yet available, something like that, for Parkinson's. Some of the genetic subtypes do involve overproduction of alpha-synuclein. but not all of them do. So some of them are more about how alpha-synuclein is broken down. Some of them don't involve alpha-synuclein at all. And so it's a bit of a tricky condition. Parkinson's probably is more of a family of diseases rather than one single entity. And so I think when we talk about a cure for Parkinson's, we should be talking about cures for Parkinson's, because I think it's probably unlikely that any one treatment is going to cure everybody, unfortunately. But the genetics certainly help with understanding the disease and help give leads for researchers. I am just browsing here. Okay, I think that's all the questions that were there for now. So we'll carry on, and there should be more time at the end. So type in questions here in the sidebar as you have them, and I'll try to address them at the end. So moving on, more treatment-related questions. So common one, isn't levodopa toxic? So when I was a young medical student, 10 or 12 years ago now, the teaching back then was still that we had to stop, not give levodopa for as long as possible to try to minimize side effects. It was still dogma at that time that if you were under the age of 70, we would start you on a dopamine agonist and save the levodopa for later. But with better data over the last decade or so, the paradigm has shifted. So lots of studies have been done since the 90s till now as to whether levodopa affects the progression of Parkinson's. So we used to think it was toxic and would accelerate the progression. Some studies done back in the 90s in New York sort of put paid to that notion. More recently, the flip side has been theorized. Well, hey, maybe if we're supplementing dopamine and the neurons that are making dopamine don't have to work so hard, maybe they'll actually be under less stress and live longer. And maybe levodopa is actually a neuroprotective treatment. So a year or so ago, a study was published that unfortunately put paid to that notion as well. And levodopa really does seem to be a purely symptomatic treatment that has no effect whatsoever on the progression of the disease. And we'll talk more about levodopa specifically in the next few slides. So will my medication lose effect as my body gets used to it? So again, this is what we used to think, that we have to hold off on levodopa so that you have the benefit later on when your disease becomes more severe. We don't think that this is true any longer. So we have this concept of a honeymoon period with levodopa. When you start, you feel good, and you should feel 60, 70% better. Some people feel essentially normal again. And you miss a dose, you don't notice, you have no side effects, things are great. That's the honeymoon period. Over time, as with all honeymoons, it comes to an end, and the doses start to last less and less time. You start to get dyskinesias, these extra movements. And levodopa will always be effective at treating the symptoms that it's good for. So levodopa, remember, is we call it a prodrug. So your body converts it into dopamine directly. So levodopa, our body's making levodopa all the time. It's the step before dopamine as our body makes its own dopamine. So all we're doing is supplementing dopamine. So the symptoms that result from low dopamine levels get better with levodopa. Unfortunately, Parkinson's is not all about dopamine. There's other neurotransmitters, other brain circuits involved that don't involve dopamine. And as Parkinson's progresses, people often get more and more of these symptoms that aren't dopamine-related symptoms. And so levodopa does not help with those, and it never would have helped with those, whether you held off on the medication or not. So we don't perceive there to be any particular benefit in that regard to holding off. And the medication will continue to work for what it works for the duration. What does happen is that the doses start to last less and less time. And we don't fully understand exactly what that's all about, but a lot of it has to do with the fact that the brain cells that make dopamine, which are slowly dying away in Parkinson's disease, are also able to store dopamine. So when you take the pill, you absorb it, your brain uses what it needs and then saves the rest up for later and releases it slowly over the next few hours. If you were to measure the level of the drug in your blood after you take the pill, you would see that the level peaks and then starts to fall again and is gone within about 2 hours or 3 hours at most. So any benefit you get from the medication beyond about 2 hours is from what your brain has stored up and uses later. As Parkinson's progresses, those brain cells are slowly dying away. And so it's like if you take the gas tank out of your car and put a smaller one in every 6 months, then you've got to keep filling the tank up more and more often. And the same thing happens with Parkinson's. It's not the entire story, but that's a big part of why that happens. So what causes dyskinesias? So again, dyskinesias are these extra types of movements that people get. We don't fully understand what causes those. What we do know is that the biggest contributor to developing dyskinesias is how long you've had Parkinson's disease for. It's not how long you've been on treatment for Parkinson's disease for. That doesn't really influence it at all. It's really more how long you've had Parkinson's for. There is some thought that maybe taking pills intermittently, so you end up with these spikes in your dopamine level, these sort of peaks and troughs through the day, that very sort of unnatural, non-physiological way of stimulating the receptors might play a role in developing it. However, people who've never taken any Parkinson's medication before can get dyskinesias after taking just one pill of levodopa. And we know that there's no correlation at all between how long you've taken levodopa and getting dyskinesias. So it's really more about the Parkinson's disease progressing. And then when you add dopamine back into the circuit, something about Parkinson's has created this circuitry in the brain to cause these extra movements. And when you add dopamine back in, you manifest them. But it doesn't seem to be the cause of the dyskinesias, if that makes sense. It's a very complicated circuitry in the brain that we don't fully understand, but it really seems to be an intrinsic feature of Parkinson's disease. Okay, so now bringing us on to the, should I wait to take medication so that the benefit lasts longer? So again, this is what we used to do not that long ago, like 10 years ago when I was finishing medical school. This is what we did. We would tie ourselves in knots to keep people off of levodopa, because the data back then was that, you get your honeymoon period is 5 years. You get 5 good years once you start taking the medication. And if you're going to get 5 good years, you're better off waiting until you're further down the road. So you get those 5 good years when you really need it. What we found out in the interim, though, and this picture is from a study, and I'll explain what it is that helped us answer this question. Short answer is we don't perceive any benefit now to waiting, and I'll tell you why. So there's this group of movement disorder neurologists in Italy who do outreach to Ghana. So Ghana, I believe, has 1 neurologist for the entire country. You think we're bad in BC with Parkinson's disease, it could be a lot worse. So these movement disorder neurologists go there and provide medical care for people who otherwise couldn't access it. So what they did is that they compared a group of people in Ghana who have issues accessing medical care to a group of their patients in Italy, and they compared them. So people in Ghana, obviously, it takes a lot longer to get diagnosed with Parkinson's disease. There's lots of socioeconomic reasons why, even if they're diagnosed, they may not be on treatment. So you're able to have a natural experiment where you compare waiting to start people on treatment. And what you can see, these bars, what they mean, pardon me, basically it's the lightest blue bar here is the time that it took from when the symptoms started to getting diagnosed. So you can see they start here at 3 years. So in Italy, everyone's been diagnosed by 3 years of symptoms. In Ghana, average was 5 years before you got treated. The next light blue bar is how long it was from when you were diagnosed to when you started on treatment. So people in Italy, about 3.5 years, people in Ghana, about 5 years. The dark blue bar is how long it was from starting treatment to developing either fluctuations, so that wearing off, or dyskinesias, or both. So you can see that in Italy, when they started at 3.5 years, on average, people had about 2 years. And this dark blue bar is your honeymoon period. No dyskinesias, no wearing off, the good times. So you have a 2-year honeymoon period, right? The people in Ghana who waited 6 years, I guess, before they or started levodopa, had almost no honeymoon period. So based on this study and a few others, it has become clear that the longer you wait to start treatment, the shorter the honeymoon period gets. And there were quite a number of people in this group of 33 people in Ghana who had dyskinesias after taking one dose of one pill of levodopa. And so we don't perceive any benefit. And now it's really when the impact on your symptoms on your quality of life is worse than the impact of taking medication on your quality of life, then it's time to take medication. And for most people, we tend to start levodopa now because it's the most effective and it has the fewest side effects. But there's no one size that fits all approach, and so the treatment has to be tailored with your neurologist. Moving along. So somebody told me that I should try cannabis. So there are lots of cannabinoid receptors through the brain. Our brain has its own cannabinoid system that we don't fully understand what it does. Based on where those receptors live in the brain, cannabis should reduce dyskinesias, or among maybe doing other things, but it should reduce dyskinesias. So far, I know there are lots of very interesting YouTube videos that I've seen. However, very few studies have been done with cannabis. The ones that have been done are all small and they have quality issues, and the results are contradictory. And part of the issue is that different studies study different things. So some of them study CBD, some of them study CBD with THC, some of them study the synthetic versions, Nabalone, Epidiolex, things like this. They study different outcomes. And so we have these essentially useless studies that don't tell us anything. So right now we have no idea. I can tell you anecdotally being the worst form of evidence, that the majority of my patients have tried cannabis, and the vast majority of them have stopped because they didn't find it helped with much. And of the people who did find it helpful, and I'm talking like 4 or 5 people probably, they found that it helped with sleep and with pain. And not many people of my patients at least, have really told me that it provides them with significant benefit for their Parkinson's symptoms. However, the devil's in the details. What are they taking? How much of what they're taking? How long do you need to take it for? What route? Is it drops? Is it edibles? Is it smoked? We just don't know. There are so many variables. There are no suggestions that CBD on its own is harmful for people with Parkinson's. So I have no problem with people trying it. I just don't want to make any promises. I do have concerns about THC, however. THC, which is in marijuana and is what makes you high, can make people hallucinate. So you have to be a bit careful with that. And people with Parkinson's are more prone to hallucinations. So it has to be used with caution. But right now, we just don't know, basically. How fast will my condition progress? It's top of mind for most people. It's really very difficult to predict. What we can say is that in general, the rate of progression doesn't change over time. So if you're progressing very quickly, unfortunately, you'll continue to progress very quickly. On the flip side, if you're progressing very slowly, you should continue to progress very slowly. If there is a very sudden change in symptoms over hours to days, so things are suddenly worse, that's usually a sign that something medical is happening. So you've got a bladder infection, your electrolytes are out of whack, you're super constipated and can't absorb your medication, something else that's not the Parkinson's is happening. So we usually direct people to see their family doctor for a medical infection workup first, before we look at the Parkinson's disease. We can generalize. So if the younger you are when the disease starts, in general, the more slowly it progresses. If you're a numbers person, the average duration of disease from onset of symptoms to death is 15 years. Sounds a bit grim, but if you think about it, the average age of onset is 65 years. Many people are diagnosed older than 65 years. The average life expectancy in Canada of a 65-year-old today is 20 years. So 18 years if you're a man and 21 years if you're a woman. Parkinson's disease is, men are overrepresented in Parkinson's disease. And so you can see that Parkinson's may shorten your life a bit, but it's not 20 years shorter, right? There are many people who start older who are skewing this average to shorter disease duration. So it is a very slowly progressive disease in general, even for people who progress relatively rapidly. how common is dementia in people with Parkinson's? Unfortunately, pretty common. So the best data that we have is that if you follow people for 20 years, 80% of them are going to have at least some degree of cognitive impairment. And again, like with progression, the younger you are when Parkinson's starts, the less likely you are to develop cognitive issues. And what you can do to prevent or try to stave off the cognitive issues is exercise, eat a healthy diet, manage vascular risk factors, so blood pressure, diabetes, cholesterol. If you have heart disease, you can have damage to your brain from that. You can have little micro strokes that accumulate over time and contribute to cognitive issues. So managing your the risk factors for heart disease and stroke also help prevent developing dementia for everybody, for whether you have Alzheimer's, Parkinson's, healthy, etc. But it is still, unfortunately, quite common. So what can I do to live as well as possible with PD? So stay engaged. So all types of activity are important. So physical activity, we talked about exercise. Social activity has also been shown to help promote brain health and slow down brain aging. So staying active with friends and family, difficult now with this pandemic, but as much as you can. Stay informed. So there is some evidence that people who are more educated around their Parkinson's disease, what to expect in the future, are better able to cope with the diagnosis of Parkinson's disease. So attending webinars like this is helpful in living better with Parkinson's disease. Give yourself permission to grieve, and this is true whether you're a patient or a caregiver. Parkinson's disease, I presume, was not part of your 5, 10, 15-year plan at any point in your life. And there is a grieving process associated with any chronic condition, whether it be cancer, diabetes, etc. And when it's something like Parkinson's disease, that grief is potentially more. And it will change over time as the condition changes over time. And it's okay to grieve, and you'll move through the stages of grief, the anger, the denial, etc., just like you would losing a loved one. And that's all part of the process, and that's okay. And recognize that in yourself, recognize that in your partner, your children, etc. So there is grieving is normal and healthy. And then prepare for the foreseeable. So, we know that over time the condition will progress. You're going to have more issues with mobility, with balance. It's always better to prepare for the worst and hope for the best. So if you need to modify the home, put grab bars in the shower, look into options for home care long before you need it, just so that you're aware of the process, right? You don't have to do it, but just so that you know what the process is, get into the system, because when you need it, there's always a wait, right? And that brings me to just a last slide, a plug for advanced care planning. All of us, if you're a caregiver of someone with Parkinson's, if you're a child of someone with Parkinson's, if you have Parkinson's at any age, at any state of health, all of us should be thinking about our end-of-life wishes. Doctors, myself included, I will admit, are terrible at bringing it up because nobody likes to talk about death. However, it's very important to think about it ahead of time. Make sure that your family knows what your wishes are in terms of CPR, in terms of feeding tubes, nursing homes. What happens if my heart stops beating? What happens if I can't breathe? What happens if I have a devastating stroke and I can't communicate? Draw up a power of attorney. The Ministry of Health has resources. If you look for BC Advanced Care Planning on the internet, you'll find workbooks that you can work through to figure this stuff out. The time to do it is now. And again, nothing is written in stone. You're allowed to change your mind down the road, but just start having the discussion. Okay. And with that, I'll stop and I will look at the list of questions. If you have any questions, type them in. We've got 8 minutes. I'll try to answer as many as I can. Okay, let me look here. Stem cells been regarded as successful research as one of the options. So right now, I would say stem cells are not ready for prime time. They're readily available. You can go out and get them. The issue with stem cells is figuring out how to get them into the brain. And I don't think that if you have an IV infusion of stem cells, which some people are offering, I don't think they're likely to get into the brain at that point. You have to get them to go to the right spot in the brain, turn into the right type of brain cell, make the right connections to replace what's been lost. And then the most important final step is to stop dividing. There have been some cases of people in research studies with stem cells who develop pretty horrific cancers because the stem cells don't stop dividing. And a cell that doesn't stop dividing is a cancer, essentially. So for right now, I would say they're not ready. They will hopefully, in the not too distant future, be a good option to repair the damage that's been done by Parkinson's disease. But for now, I would not go for that right now. For sure, we got all that done. The research paper from Italy. So if you, I'm not sure if it's publicly available or if it's behind a paywall. The question from Rav as to where they can find the research paper from Italy. So it's, if you look for Cilia, that's the author. So Roberta Cilia is the author. And if you look for, Google that, I think it was published in 2014 or 2016, Parkinson's disease, and yeah, you should find that paper. Again, I'm not sure if you have to have a subscription to through a university or the thing to find that paper, but it's out there. That's one, and there are other similar evidence that supports the findings of that paper. Someone with long-standing bipolar disorder presents with Parkinsonism. Levodopa may not help much if it is due to toxicity, correct? So potentially, people with bipolar disorder are treated with a variety of or could be treated with a variety of medications that can cause Parkinson-like symptoms. So antipsychotic drugs like olanzapine, risperidone, Haldol, lithium, valproic acid, can all cause Parkinson-like symptoms. The antipsychotic drugs work by blocking dopamine receptors, and if the receptors are blocked, it's hard for levodopa to access them to work. Levodopa can still help a little bit, but the concern then becomes, is it just, your brain is aging and not tolerating the drug anymore, so you're starting to have side effects, or is it that your brain is aging and you're also developing Parkinson's disease? And that can be a very difficult question to answer. Obviously, if you have Parkinson's disease and bipolar disorder, over time, that might limit the options that can be used to treat the mood disorder without making the Parkinson's worse. And then it becomes a difficult juggling act that needs your psychiatrist actively involved in the treatment. But we'll still often try it. I mean, realistically, if someone has Parkinsonism, regardless of the cause, we tend to give them drugs like levodopa because, if anything's going to help, the levodopa probably will. But it might not always work as well. So what about DBS? So DBS, deep brain stimulation, is a good treatment for people with more advanced Parkinson's disease who are having lots of dyskinesias or lots of wearing off. It's not perfect. It only works for symptoms that respond to levodopa, again. So if you've got a lot of, if quality of life issues are really driven by those non-levodopa responsive symptoms, then DBS won't help as much, but still could be an option depending on the individual. Access, of course, is dismal in BC, which is another topic for another day, but it's a good treatment. The maximal dose of Sinemet is where you start having intolerable side effects, essentially. So I have patients with quite advanced Parkinson's who are taking like 200 milligrams of levodopa every 2 hours or every hour and a half around the clock, which is obviously not optimal, but you can be on quite high doses. We just have to monitor for side effects. Severe leaning over to the left side. So those postural abnormalities, so either the lean or the stoop, those are challenging to treat. We don't fully understand why people get them. Some medications, particularly dopamine agonists, may make them worse. And so sometimes if I see someone with a severe postural abnormality, I'll try to get them off of their dopamine agonist, which is usually a long, slow, painful process. Often physiotherapy, it helps more than any medication will. So working with a good physio who can help repair some of those muscle imbalances. But there's still disagreement about whether those things are due to weakening of muscles or overactivity of muscles. So it's a bit challenging, unfortunately. I found a difference between Sinemet and generic levodopa. So so is there a difference between Sinemet and generic levodopa is the question. It depends a little bit. many people find that the controlled release, so Sinemet CR, the brand name, much more effective than the generic levodopa/carbidopa CR. That is a very common thing that we hear. By and large, it's vanishingly rare to hear anybody that notes a difference between the IR formulation. So the regular release Sinemet, the only real difference with the generics is some of them don't stand up well to humidity, and the pill kind of crumbles, but they are equally effective. Lots of people notice the difference between the CR and the IR, though. Often what I've done is try to switch people over to the IR because it's more reliably absorbed, and most of the time that helps. The other thing is, if you've gone to generic from the brand, sometimes increasing the generic of the CR will help. The CR formulation, the absorption is erratic at the best of times, and the generic seems to be a bit more so. Okay, so I think we're at time. Alana, am I right? I think that was all of the questions that I saw. I'm sorry if I missed any.
No, I think those are all of the questions. So I think we could probably wrap things up. Thank you so much, Dr. Squires, for taking the time out and doing this webinar for us and sharing your knowledge and expertise to answer those frequently asked questions. So thank you so much. And thank you all for attending. Really sorry about those few of you who had some audio issues, but hopefully they did resolve. So thank you so much. And don't forget to check out SuperWalk. The SuperWalk link is in the chat box. So please do click on that as well and find out what that's about, and hopefully register. Thank you.
Have a great day, everyone. Stay well.